the audience. Thank you for the invitation. It's a privilege to join you for some talk on and some thoughts on the guidelines. I think one of the most important, the first important point I would like to emphasize, which was already mentioned by the chairman, is the fact that those were the first joint guidelines. And actually, we were reached by the ESC, who reached EACTS in about 2007, 2008 to develop the guidelines. And I think it's rather important because I'm quite sure that if the guidelines had been developed only by PCI guys, for example, some, not obviously all, but some of the recommendations could have been different. And these guidelines were chaired by William Waynes, well known, I guess, who is also the chairman of EuroPCR, and myself for EACTS. And the task force members were composed by about a third of interventional cardiologists, a third of non-interventional cardiologists, and a third of cardiac surgeons. And I think this balance is quite interesting because even in the cardiology practice, our colleagues don't always have the same opinion, whether they work in the cath lab or they actually are imaging guy or prevention guy, for example. These guidelines that were published in 2010 were quite large. They did encompass all aspects of coronary artery disease, scores and risk stratification, decision-making, imaging, revascularization according to clinical presentation, stable, but also non-STEMI and STEMI. Even though later on in 2011 and 2012, the ESC has released new guidelines on respectively non-STEMI and STEMI. We also address special conditions such as diabetes, patient with chronic kidney disease, valve disease, heart failure, cross-revascularization procedures, and so forth. We also had two specific chapters on procedural aspects of both CABG and PCI. And for the first time, we actually included a full chapter on antiplatelet and antithrombotic pharmacotherapy that was not placed in each section. And one of the reasons was the new development, especially regarding prasugrel and ticagrelor. We also finished the guidelines with secondary prevention and strategies for follow-up. Obviously, I will not cover everything. It will take an hour and a half. I will emphasize some chapters, the first being the process for decision-making and patient information, including the heart team. I think it's quite important. There will be a session after the pause later this morning talking about what information should come to the heart team, and hopefully that will be a very interesting session also. What we said, and that's actually the first time that was written in stone, if you consider guidelines being stone, that a patient with coronary artery disease should be placed at the center of the decision, of the process of decision-making, and that the heart team should include a non-interventional cardiologist, an interventional cardiologist, and a cardiac surgeon when possible. And as I said, this is a reflection also of the composition of our task force. We sometimes had very difficult discussion, but we always were able to reach an agreement, and I think it's important. Now, obviously, when a patient has comorbidities, and we are dealing more and more with elderly patients and patients with kidney disease or lung problems or liver insufficiency, well, then you need to expand the heart team and include numerous other medical specialties as listed on this slide. Now, we came with these two recommendations. It is recommended that patients be adequately informed about the potential benefits and risks, both short and long term, of any revascularization procedure, and that enough time should be spared for informed decision making. Second, the appropriate revascularization strategy in patients with multivessel disease, so not all lesions. Multivessel disease should be discussed by the heart team, class 1 in both cases, and C-level recommendation. I will discuss that in more details in the second session this morning. Now, when you develop guidelines, you come with classes of recommendations and level of evidence. One being the highest, 3 don't do it, and level of evidence, it's A, B, C, A meaning at least 2 randomized controlled trials or 1 meta-analysis, B, 1 randomized controlled trial or very large registries, and C, it's usually small studies or consensus of opinion of the experts. Now, if we look at our guidelines, about 45% are level C, which represent expert opinion in the absence of trial-based evidence. And the recommendation to discuss the patient within the heart team is obviously level C. There are no trials for that. But it doesn't mean that a recommendation on a level C is weak. You know, there is the famous quote that parachutes appear to reduce the risk of injury, but the effectiveness has not been proven in randomized controlled trial. So it's a level C. But I would not jump out of a plane without a parachute. So it doesn't mean it is weak. Now, having said that, I mean, obviously, when you think about time and discussion and heart team, you have two options. Either the patient is on the cath table and he or she will get the therapeutic procedure, the PCI, immediately. That's what you would call ad hoc PCI, or revascularization at an interval by PCI. CABG, obviously, you don't do it on the cath table, so that's always at an interval. So ad hoc PCI is an immediate procedure done on the same session, not in a different sessions. While what we said also is that institutional protocols designed by the heart team should be used to define specific anatomic criteria and clinical subsets that can or cannot be treated ad hoc. And we do not recommend a systematic review of all angio. Obviously, that would not be impractical. What we said, and I will come back to that later in the second session this morning, is that heart teams should also define protocols. And a protocol can be different across institutions according also to the expertise of all our colleagues working in a specific setting. So what we said would be, in our mind, the potential indications for ad hoc PCI would be, I mean, obviously, patient with STEMI or non-STEMI, including those in hemodynamic shock, they should have culprit lesion treated immediately. Ad hoc culprit lesion doesn't mean if you have a patient with non-STEMI and he has multi-vessel disease, only the culprit lesion should be treated and the other lesions should possibly be discussed later. Stable, low-risk patient with single or double vessel disease, and that's proximal LAD excluded. That's obviously a source of a lot of discussion, and non-recurrent restenotic lesions. So we did acknowledge that ad hoc PCI is convenient for the patient, associated with fewer access site complications, and often cost-effective. It is reasonable for many patients, not for all, and it's not a default approach. And I think just mentioning that, you know, doing ad hoc PCI for economic purpose, it's not appropriate. It's not enough. Now, on the other hand, at an interval, we recommended lesions with high-risk morphology, chronic heart failure, renal failure, stable patient with multivessel disease, including LAD, ostial or complex proximal LAD, and very complex lesions. Now, what is also interesting is what we said regarding the following: hospital teams without a cardiac surgical unit or with interventional cardiologists working in an ambulatory setting should refer to standard evidence-based protocols designed with an expert cardiologist or cardiac surgeon or seek the opinion for complex cases. So the guidelines also encompass what should be done in a specific center without, for example, cardiac surgery on site. Now, having said that, let's go to indication for revascularization in stable angina or silent ischemia. That will be the main part of my talk today. There are two things. The first thing is, should we revascularize the patient? Because sometimes optimal medical treatment is enough. And the second thing is, if we do it, which technique should we recommend? So regarding the first, you are well aware of this publication that dates 10 years ago by Hashamovich, showing, comparing actually medical treatment and Revasc. And you can see very clearly on this slide that the curves, the lines actually cross at about 10% of ischemic myocardium, meaning that above which the survival benefit to revascularization over medical treatment increases as a function of increasing amounts of inducible ischemia. And I think 2 years ago, Hashamovich actually published another larger series, and the same conclusion came up actually with a little higher amount of ischemic myocardium. I think now it's about 12 or 13%. So I think it's very important. We should not treat an anatomic lesion. We should treat a functional lesion that is responsible for ischemia. Ischemia being demonstrated either with a stress test or measuring FFR in the cath lab. So that's what we said in our recommendation. And what we also did is we divided the indications for revascularization either for prognosis or for symptoms. Those are not the same. I mean, sometimes, obviously, you treat both. You treat a symptomatic patient and you improve his survival. So what you can see here, the indication for prognosis, they are quite clear: left main, proximal LAD, 2 or 3 vessel disease with impaired left V function, proven large area of ischemia, and single remaining patent vessel. And I would like to emphasize the presence of the asterisks there. These asterisks relate to documented ischemia or significantly decrease below 4.8 fractional flow reserve. And here you have the indications of treatments for symptoms which are different than for prognosis. Now, the heart team agrees on the indication for myocardial revascularization, and I think this notion of ischemia is really important. Then, which technique should be recommended, PCI or CABG? I mean, we obviously reviewed all the available evidence in 2008, 2009 when we developed the guidelines, all the registries, the trials, the publications, and Professor Taggart was very instrumental in this part. And obviously what we also had is the syntax trial. The syntax trial is extremely important for numerous reasons. One being it's an all-comer trial. All patients with multivessel disease are discussed within the heart team, and they are randomized either to CABG or PCI if both techniques are possible, and if not, they are versed into a registry, either CABG registry or PCI registry. You are certainly well familiar with the design of the syntax trial, and it is both sides of the Atlantic trial. I think it's also quite important. We also have to acknowledge that the hypothesis of this trial was non-inferiority for PCI using paclitaxel-eluding stent, and this hypothesis was not met because PCI was inferior. So all subsequent analyses, like looking at left main or diabetes subgroup, they are hypothesis generating only, and this is the reasoning for having other trials, such as, for example, the Excel trial for left main. Nevertheless, there are very interesting observations that can be made in subgroups. So having said that, and having in 2009 the first year result of the syntax trial, this is what we recommended. So what we did basically is that we recommended either favor CABG or favor PCI according to the subset of CAD by anatomy. I would like to emphasize a couple of things. The first is the title of this slide. Indication for CABG versus PCI in stable patients with lesions suitable for both procedures and low predicted surgical mortality. I mean, there's no question that if you have a patient, even with a high syntax score, but who is 85 and has kidney insufficiency, that's probably a different story. Those are typically syntax trial patients. And the second thing is, obviously in most situations, the evidence favors CABG. But I don't think that this slide should be seen or presented as a victory of surgery versus PCI. In numerous instances, it means that the patient should be discussed within the heart team. If you look, for example, at patients with 3-vessel disease and low syntax score up to 22, you have 1A and 2AB should be considered, is recommended. So both options are fine, as long as we understand the difference, and as long as the patient understands also the difference. And the same for left main. You see, this is the first time that we give a 2A recommendation for isolated left main, and a 2B for more complex left main lesions. So most cases discussion, and obviously in the most severe patterns of CAD, essentially with high syntax score, CABG appears to offer a survival advantage as well as a marked reduction in the need for repeat revasc. Now, those are recommendations from 2010. We are 2013, and already a few months after the guidelines were released, we heard, for example, by Marie-Claude Maurice, who I like by the way, that the guidelines are both biased and outdated. Well, I don't think they are. I don't think they are biased. We just stick at data, and I don't think they are outdated. And now we have the results, the 5-year results of the syntax trial. And if you look, this is what we have now, 5-year follow-up. We have some more patients in the PCI group available as compared to the CABG group. That's a small weakness, obviously, but it's not very significant. And if we look at 3-vessel disease subset, because I think it's very different if you compare 3-vessel disease and left main disease. This is the difference for all-cause death to 5-year, all groups, all group with 3-vessel disease. Here, there is no stratification according to the syntax score. It favors CABG with a 5% or 5.5% difference. This is cardiac death. It also favors CABG. This is myocardial infarction. It is also significant with a 7% absolute difference in risk. This is stroke. There is no difference overall for the 3-vessel disease group. That's a different story in the left main group. This is all-cause death, CV and MI. So that's what you would call hard endpoints, removing repeat revascularization. 8% difference in favor of CABG, 3-vessel disease. This is repeat revascularization, 13% difference in favor of CABG. That's obviously a weaker endpoint. We have to make sure that patients understand what it means. And then you have MACE, the primary endpoint, at 5 years, 13% difference in favor of CABG, so that's an inclusion of all MI, death, stroke, and repeat revascularization. Now, if you look at the tetiles, if you compare them, you have here the patient with 3-vessel disease and a low syntax score. You have no difference but in Revasc. So here you can say that PCI is probably okay, as long as the patient understands that there is a somewhat increased risk of repeat revascularization. What about intermediate score? That's a different story. You have a significant difference in favor of CABG, and this is true both for death, MI, hard endpoint, and repeat Revasc. No difference in stroke. And that's even better for CABG for patients with high syntax score that is 33 or above, with a 17, almost 18% difference with an increased risk of cumulative event associated with taxus eluding stent, and you can see here the differences. Now, if you look at left main, well, as I said, this is hypothesis generating only, and left main, not all patients with left main have the same lesions. Some have isolated left main, it's very few. I don't think you can draw a lot of meaningful conclusion with 91 patients. That was not powered for that. And then you have left main associated with 1, 2, or 3-vessel disease. So most patients, excuse me, with left main disease have actually associated lesions. Now, in the left main subset, there is no difference according to for all-cause death up to 5 years. There is no difference in cardiac death. There is no difference in MI, a little bit in favor of CABG, but this is certainly not significant. Now, concerning stroke, CABG has an increased risk, and that's, we should acknowledge, this is well known from registries. Patient left main have an increased incidence of carotid lesions, for example, and more peripheral arterial disease. And maybe also some increased incidence of aortic atheromysia. It's very well possible. Repeat revascularization, there is a difference in favor of CABG. And then we have MACE. Well, there is no difference. If we take all patients with the left main subset, there is no difference. So I think here you have some equipoise, and that's why we do the Excel trial. Now, all, as I said, the left main disease are not the same, and if you go from left main only to left main associated with 3-vessel disease, you can see really a different pattern. In favor of PCI with left main only, and in favor of CABG when it's associated with 3-vessel disease, this is significant. Now, if you look at the tetiles within the left main disease, you can see that for low score, there is absolutely no difference. So both techniques are just fine. I mean, fine. You still have a 30% event at 5 years, but that's the same event rate. For intermediate score, you also don't see any difference.
exactly the same. And for patients with high score, then there is a difference. So, you know what? I mean, at 5 years, the recommendations that we made 3 years ago at 5 years of the syntax trial are fine. They have not changed. They actually are reinforced. Now, you can say that, you know, we have new stents, we have new drugs, we have new techniques. That's true, but we have to test them in trials. Now, to say that and to conclude, I mean, what about implementations into clinical practice, which was a question that I was asked to address? Well, some surgeons probably would like to come back to the very old days when, you know, you have the cardiologist coming and giving us the heart and we are on a throne. I think we should forget, I mean, obviously, for that, and that's very good that we have to forget that. Now, someone said recently, I mean, a couple of years ago, that the future treatment of most cardiovascular disease lies in PCI, in percutaneous interventional techniques, because it's not only PCI, it's also TAVI. And you would think it's maybe, you know, Patrick Serrais or Greg Stone or Martin Lyons. Well, actually, no, it's one of our, it's a cardiac surgeon, it's Rüdiger Lang who said that. Now, he's trying to work at the Munich Heart Center with a cardiologist, not always easy, but he's moving there. Another interesting citation quote is from Michael Mack, who said, "Fool me once, shame on you. Fool me twice, shame on me." A perspective on the emerging world of percutaneous heart valve therapy. What it means is that with TAVI, I mean, we should, as surgeons, work with our friends and colleagues, the cardiologists, and develop things together. And I think actually it is very interesting that usually heart team discussion is quite easy for valves, but it's more complicated for myocardial revascularization, and it should not be the case. Now, maybe hybrid revascularization strategies is a route also that we could think about and pursue to work more together. We have no trial, so it's only a maybe considered, but I think it's reasonable to think about it. Huh? The highest benefit for surgery is probably the LAD. That's something I would like to discuss maybe a little bit later. So the concluding remarks that we had in 2010 was that these guidelines represent a new collaborative effort between cardiologists, both clinical and interventional and cardiac surgeons, to manage the whole spectrum of CAD, from optimal medical treatment to PCI with stents to CABG. Implementation of the heart team approach is best for patients and doctors by promoting and emphasizing transparency in decision-making, patient choice, and informed consent. The guidelines emphasize the importance of optimal medical treatment and lifestyle changes in all patients with CAD. Obviously, if a patient has a stent or get CABG, its lifestyle change is extremely important. And the guidelines indicate when optimal medical treatment will suffice, and when revascularization by additional intervention using stents or CABG is appropriate. Concerning implementation into clinical practice more specifically, well, that's very difficult to assess that. You know, we have no real studies, certainly no trials, and very few publications, so it's difficult to assess the precise impact of our guidelines. The key points are probably heart team discussions. I really think they are very important. It's also a way to get to know each other. Systematic score calculation, and didn't mention that for the sake of time, but calculation of the Euro score, of the syntax score, of the STS score, I will develop that a little more later this morning. Revascularization based on functional assessment. I think it's very important. We should not just treat a lesion, but we should treat a functional lesion. Patient information, I think that's a key. Now, from the guidelines, we also have new antiplatelet agents, and I'm thinking about ticagrelor, and you may be aware that we are just about to start a new trial called ticagrelor in CABG. I'm one of the steering committee member. Professor Schunker from Germany is the principal investigator, and the goal is to compare ticagrelor with aspirin, with 1 year after CABG being the primary endpoint, and that would include both patients with ACS before surgery and stable patients. 4,000 patients should be included. What is also very interesting, I believe, concerning implementations of the guidelines, that the heart team is now recommended in American guidelines. Our friend across the Atlantic, both in PCI and CABG guideline, did recommend the heart team, and that's also a 1C recommendation. So I think it's a good sign. The recommendation developed in 2010 actually hold firmly, or rather firmly, in 2013. And we actually have already started to think about new guidelines. They probably will not change that much, but we already have started meetings and thoughts, and our goal is to release a new version of these joint guidelines, again, ESC and EACTS, within a year and a half in 2014. That will be a joint effort again. So I think we are making progress. It's not changing every day, but I think it's a slow but progressive impact, and we should keep going. Thank you very much.
Thank you very much, Philippe. It's so great to hear the guidelines discussed by someone who is fundamental in informing them, and you've got a huge knowledge. If there are questions, we've also got I've got the guidelines here going through them. And as you said, not a lot has changed since they were published in 2010, and in some ways the recommendations have been reinforced by the publications since. But as many of you will know, the guidelines were written on data from 2008 and 2009. What do you think, of all your recommendations, what do you think will be the main changes in the revision coming up? Are there any aspects of the guidelines that you think will change?
Well, first, we are not supposed to discuss publicly what we discuss in the group because it may change. Well, I would assume that some recommendation, for example, for left main could be upgraded in favor of PCI. I wouldn't see any problem with that. On the other hand, I think that for a patient with three-vessel disease and high syntax score, they probably should not change too much. We also have, as I said, new guidelines on non-STEMI and STEMI, the new agents and so forth. So I think we probably will keep high-level recommendation for prasugrel and ticagrelor. I think they are just better than clopidogrel. I'm talking here for most acute coronary events, so not for surgery. And then you have all the discussion about, the subgroups, taking into account the FREEDOM trial, the STITCH trial, the 5-year results of syntax and everything. We may present things somewhat differently, but from what I think at this stage in March 2013, there is not a lot of change.
Good. And that's in some ways very reassuring that things aren't changing too dramatically. Are there any questions on the actual guidelines from the audience? We've got the master with us to answer. So it's a small room. Don't be hesitant about asking. This is your opportunity. Absolutely.
You can probably hear me. Sorry. Just a couple of points, if I may, on that. I mean, it's disappointing that there's 12% loss to follow-up in the CABG group in syntax, because we don't know what's happened to those patients, so we have to be careful about the conclusions that are drawn. I think what Marie-Claude was alluding to was that it's disappointing to put too much reliance on a single trial. Of course, it's inevitable because that's the best evidence that we have, but it does relate to data from some years ago with a stent that's now obsolete and has been superseded with very significantly improved results with newer stents. Now, I know we are continually saying that in cardiology, but
I know
but the fact is, it's true, and the actual percentage improvement, if you look between the everolimus-eluting stents and the old Taxus, which is syntax, there is really a very substantial difference, which, with due respect to surgery, is probably greater than the relative difference in improvements that have been made in surgery. So I think that's what she meant by saying that the guidelines are, and almost inevitably, always lagging behind current data.
Well, it's true, but on the other hand, we don't have trials comparing CABG and PCI with everolimus eluting stent with second generation, and we have some, not huge trial, but we have smaller studies, and still CABG usually do better in patients with multivessel disease. I recently reviewed a good paper for the Annals of Thoracic Surgery where they compared, and they asked me to write an editorial, where they compared off-pump CABG and patients with who had everolimus, I think, a second-generation stent, and the results were better for CABG. So I would agree that paclitaxel is certainly not the best. The stent that we had in 2005 when the trial was started or something like that, then we should do another trial. We should do just exactly the same trial and compare and see. On the other hand, remember that in the syntax trial, most patients did not have double mammary artery, they had single mammary artery, so it's rather all-comer trial.
Sure.
But there are points for discussion, I agree.
Just before we go on to the next speaker, and please put your hand up if you've got any questions, but can I just ask the audience, how many of you from your units think that you have a functioning heart team of surgeons and cardiologists, interventional, non-interventional? Okay, and how many of you feel that the patient then gets information at their level, whichever level they are, that they are part of the decision after that? So how many of you think that your patient is actually involved in the decision? Okay, thank you very much. Interesting. Just to say, from where I'm sitting, that was about 2/3 of the room have a functioning heart team, and there's about 6 or 7 of you think that the patient actually ends up informed in the decision or involved in the decision in the end.
Can I just make I guess, an observation about the guidelines, which clearly are a mammoth piece of work and extraordinarily useful, but it's my sense is the difficulty, if you like, of laying those guidelines into a context where we deal with patients on a day-to-day basis. So, for instance, 2/3 of most units' work is now emergency or non-elective. And that will, by necessity, skew the way in which certain patterns of disease are treated because of the way they present. So suddenly a patient with left main and 3-vessel disease who presents with a STEMI is going to be managed percutaneously in one way or other, at least in the immediate phase. The non-STEMI, I think, gives an opportunity for discussion and pause. So instead of treating the culprit lesion, if there's clearly a surgical pattern of disease, you could step back and say, well, hold on a second, if we can settle things down, this patient could then be a very reasonable surgical candidate. But then the practical issue becomes when and how soon after that presentation can such patients be fed into the surgical schedule. And I think that reality, that practicality has to apply to some of this.
Yeah, I agree. I didn't develop non-STEMI or STEMI, but we mentioned that. I mean, for non-STEMI, we emphasize the importance of the risk score, the gray score, and patient with a grade score over 140 should have immediate go to the cath lab within 24 hours, not immediate, but it means, that it should be done during the weekend, for example. So that was a significant recommendation. For STEMI, we did recommend immediate PCI and transfer to a center if it's needed, so no fibrinolysis, and even patient that had successful fibrinolysis, immediate transfer to have cath within 24 hours. Now, I agree. I mean, obviously, if you talk about comparing PCI and surgery, for acute events, there is no question that PCI has a huge role. And also, from my mind as a surgeon, I think that the cardiologists have done a great job there, in improving a lot of survival over the last 20 years. And I think they should keep fighting there. And in my opinion, it's much better and much more important to treat this patient with ACS as opposed to put 6 or 7 stents in a patient with syntax score of 45. Because whatever the stent, I'm sure it will not be as successful as CABG. The reason is CABG doesn't treat the lesion. It's a bypass. And then I'm sure David will emphasize that. And why PCI actually treat the lesion. So whatever the quality of the stent, we don't exactly treat the same thing. And this, I think it's a very, very important point. To come back to the notion of having time, the typical question is about patient with proximal LAD. And, a lot of time we hear, well, he's on the cath table, I can fix that right away, and the patient, will accept that. Well, it's probably true, but it also depends how much time we give the patient to think. Honestly, if I'm 48, if I have a proximal LAD lesion, I would like to think a little, unless it's an acute event, I would like to think twice. I honestly, as of today, this morning, I don't know if I would prefer a stent or if I would prefer a lima to the LAD. It probably will depend on who does the procedure, certainly, and also what the complexity of the lesion. because it's if calcified and the first diagonal is in the lesion or not. Those are different story. And these things, if the patient has 5 minutes to think about, he will go for PCI. I honestly think so. Yes?
Thanks. Hi, I'm Adrian Marchbank from Plymouth. I think the crucial thing about this is that they're guidelines, and that refers very much to Simon's point about a functioning heart team. And what these, our view certainly is that these act as a basis for discussion. They're not protocols. They don't state that if you have this complex set of lesions, you must have this treatment. They act as a basis for discussion, and the best thing I think about it is that they bring cardiologists and surgeons together to have a formal discussion about things.
Yeah, that's true that if you do look at the NICE guidelines, for example, or the American guidelines, they're much more complex. They're much more difficult to read because then you say, and then before the guidelines in the US, you have appropriateness lesions that were developed by all these scientific bodies, and that's very difficult to read because then you have to look at a lot of other events or other conditions before deciding what to do. It's a go. And if you look at what we said for ad hoc PCI and for revascularization at an interval, we didn't give a class of recommendation of level of evidence. We were very diplomatic. We said potential indications for ad hoc PCI, potential indication for revascularization interval, and this is presented as a heart team proposal, the heart team being the task force that developed these guidelines.